Well, good morning, everyone. I am Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we will go ahead and get started with some reminders and announcements, and then introduce today's speaker. Next week, please be sure to join us for the talk Gender Affirming Therapy for the Transgender Patient, a review given by Dr. Cody Paiva. We are here live at Providence St. Vincent Southern Auditorium. And as a reminder, Grand Rounds is now a joint effort between Providence St. Vincent and Providence Portland Medical Center. We are often here in person at 8 a.m. on Tuesday mornings, sometimes live in person at noon at Providence Portland. And you can always watch Grand Rounds virtually on live stream through Teams Live. You can earn CME credit by being here in person, watching live virtual, or watching a recording of the event, and that recording is always available as the same link as the Grand Rounds invite. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions for those of you online, and I will mostly hold those to ask as time permits at the end. I am particularly excited to introduce today's talk and speaker. Today is our 2024 Florence Edelson Memorial Lectureship. And this lectureship was established in 2002 by Helene and George Edelson to honor the life and memory of George's mother. Her husband, Dr. Jesse Edelson, was a St. Vincent physician for many years. Today, we are joined by Dr. Lin Chang, Professor of Medicine and Vice Chief of the Vache and Tamar Manukian Division of Digestive Diseases at the David Geffen School of Medicine at UCLA. She serves as a co-director of the G. Oppenheimer Center for Neurobiology of Stress and Resilience and the director of Clinical Studies and Database Core for the Goodman-Luskin Microbiome Center at UCLA. She also serves as the Gastroenterology Fellowship Director, and Dr. Chang's clinical expertise is in disorders of gut-brain interaction. Her research focuses on brain-gut interactions underlying irritable bowel syndrome, specifically the pathophysiology of IBS related to early adverse life events, stress, sex differences, epigenetic factors, and gut microbiome, and the treatment of IBS. She is a member of the Rome Foundation Board of Directors and previously served as president of the American Neurogastroenterology and Motility Society, as well as the clinical research counselor of the AGA Governing Board. It is truly an honor to have you join us and teach us today. Thank you, Dr. Chang.
Morning. Thank you, Laura. Thank you, Tom, for the invitation. I hope this is helpful to you, and I really try to give talks where it's going to be helpful to you and then obviously to your patients. So I made it, I like to cover the whole entity and give you some evidence, but I also I'm going to throw in practical tips for you because to me, that's always really important. These are my disclosures. So today I'm going to review the diagnostic approach in IBS patients and also describe just briefly the pathophysiology of IBS and then describe the evidence-based and practical treatment algorithms for IBS with diarrhea and with constipation. There is a mixed group, the mixed bowel habit, where people alternate between diarrhea and constipation, but it's been very difficult to decide the endpoints for those trials, so you don't see many studies with them. But if you want to ask me, I will tell you how I manage them. Because they make up a third. So it's a third IBS diarrhea, a third IBS constipation, a third mix. There was a very large global epidemiology study that was done by the Rome Foundation. And you can see many different countries that were never even surveyed in the past, looking at any what we call disorders of gut-brain interaction, which I'll describe in a second. This is the data on IBS. So IBS, the criteria change. It's so funny. We change it every 10 years. Now it's going to change in 2026 back to what it was in 2006. It wasn't successful in 2016 because it was a little bit stricter criteria. But anyways, the prevalence is anywhere between 4 and 11% in the world, depending on which criteria you use, but it's very common. So this study looked at the prevalence overall, women and in men. of any what was called at that time functional GI disorders. We've switched the name to DGBI, and I'll explain that. So you can see the different disorders all the way from the esophagus to the anal rectal area. IBS is just really more the common one that people know. And in fact, I hear a lot of patients or physicians diagnosing patients as IBS, meaning that there's unexplained symptoms of abdominal pain, bloating, or discomfort. But IBS has certain criteria. It could be that the patient has functional dyspepsia or something else. But if you look, so functional dyspepsia is one of the more common ones, and that means that the patient has epigastric pain, burning, or early satiety. That's not related to bowel habits. That's functional dyspepsia. And if you look at functional dyspepsia, the patients that have postprandial symptoms, that's more common in women. If you look at IBS, it's more common in women than in men. In particular for constipation. Constipation in general is more common in women than in men. So if you're going to see a man with IBS, they usually will have the diarrhea subtype or maybe the mixed. They more infrequently will have constipation. And bloating, of course, is more common in women than in men. There has not been that much data on the diversity and health disparities in IBS. There's going to be more that you're going to see. In this one very, very large study of over 5,000 individuals with Rome, and they surveyed over 88,000 people. This is a survey study. They found that non-Hispanic Blacks, Asians, Hispanics, and other multiracial groups were less likely to have IBS than whites. It was more common in women. It's actually more common in smokers and those with comorbidities. And this is something that's really important. And I was telling Laura and Tom that I started my career in research of looking at the overlap of IBS and fibromyalgia. But IBS is one of these other somatic or chronic pain conditions that you are going to see with migraine headaches, interstitial cystitis, temporomandibular joint disorder, chronic pelvic pain, and fibromyalgia is the other big one. So obesity, surprisingly, and I know people are not expecting it, it's actually associated with IBS diarrhea type, not the constipation type. And there's a number of studies that have shown that. And then many patients never seek healthcare. This is a busy slide, but I just want you to know that this just the key points, because I put this in PPS mode, so I realized I couldn't actually alter it. But the racial and ethnic minority IBS patients are more likely to be managed by PCPs rather than by GIs. Often men and Blacks are less likely to be given the diagnosis of IBS than in women. And the costs for men is lower than in women. The healthcare costs and IBS-related costs are lower in Asian and Hispanics compared to whites. But Blacks have a higher total IBS-specific costs with prescriptions and then IBS-related radiology costs. But the emergency room visits and emergency room visits, but the endoscopy costs were lower. And Asians and Hispanics do have lower costs for IBS-related services. So there's some gender differences and there's some race ethnicity differences, and you can integrate them and they're different. This is the first paper that a colleague of mine, it's almost accepted, where we looked at gender and race ethnicity at the same time, which a lot of people just look at one or the other, but there are differences. So when we see a patient, we're thinking about all these disorders, definitely as gastroenterologists. And I have to tell you, there's just another one every couple of years, because I've been doing this a long time. We go down these different paths and we realize that maybe they have it, maybe they don't, and then you move on to another disorder. Right now we're in the mast cell disorder, where a lot of patients are thought that they have mast cell disorder. And then there's alpha-gal syndrome, which is newer, but I don't think I have time to talk about it. So I am going to just show a fairly simple diagnostic algorithm. So you always start with symptoms because that's what the patient is coming in with. So the patient has recurrent abdominal pain that's associated with a bowel movement change. That's the key. The pain and discomfort have to be associated with diarrhea, constipation, or both. If they don't have that link, it is not IBS. It could be centrally mediated chronic abdominal pain syndrome, could be functional dyspepsia, it could be just chronic constipation, but it's not IBS. IBS is the link between the two. So you usually do your medical, surgical, psychosocial, dietary medication history, digital rectal examination, which I don't know how many actually there was a study that showed primary care physicians don't do it very much. Even GIs don't do rectal exams, but they're really important for fecal incontinence and for chronic constipation. And fecal incontinence, you're really looking for weakness. But the chronic constipation, why it's important, because I'm not going to talk about this later, is that some patients, a substantial number of chronic constipation patients, don't get better with usual treatment because they have a pelvic floor dysfunction. Their pelvic floor anal rectal area does not relax, so you can't straighten out the rectum and evacuate. So if you're going to just keep giving them laxatives, they're not going to respond. About 10 to 20% will respond. So you really want to identify if they have that. So you refer them to anorectal manometry or pelvic MRI to determine, because if they have it, you need to send them to pelvic floor physical therapy or anorectal biofeedback. They're not going to really get better if you just keep giving them medications by mouth. So I always try to explain to patients, like you're going out the exit of a door and it's partially closed, but someone keeps trying to push this whole group out the door. You know, it's going to be hard for that to happen if you're not opening the door. So that's really about so that's something I just want to remind you of, and that's the reason why we do digital rectal exams, in addition to looking for rectal masses. Okay, so we're always thinking about all these other conditions the patient can have. We typically think about colon cancer, inflammatory bowel disease. So one way to really think about is look for alarm features. If they have alarm features, you're going to do a more aggressive diagnostic workup. Many times you won't even find that other condition. It'll be blood because of hemorrhoids. It's not explaining their pain and diarrhea, constipation, but you have to do it. But most patients don't have alarm features. They've had this a long time, hasn't really changed. So you really do limited diagnostic screening, which I'll show you. If you find an abnormality, you would treat it. But if you don't, then you can make a symptom-based diagnostic diagnosis of IBS, and then you move on. These are alarm features. I'm sure you've seen this slide many times. So the first one, you're going to see a patient over 50, but you want to know, their symptoms just start after 50? And most of the time they started earlier. They'll have some kind of abdominal symptoms, maybe growing up in their 20s and 30s, but it's a red flag only if they didn't have any of these symptoms, they have it. And then having unintended weight loss, you always have to ask, were they on a diet? You know, are they on some med? And then rectal bleeding, where you don't think it's more than hemorrhoids. Waking up in the middle of the night to have bowel movements is a red flag. Waking up in the middle of the night with pain is not a red flag. That's pretty common, but they don't wake up to have diarrhea. Then I'm always thinking it's something else. Maybe it's microscopic colitis, bile acid diarrhea, or I'm thinking something else. Occasionally can happen in IBS patients, but it's not common. Fever, of course, family history of colorectal cancer, inflammatory bowel disease, celiac disease pushes them a little bit more of trying to look at those conditions, and then unexplained iron deficiency anemia. Okay, so if you don't have the patient doesn't have those red flags and have the pain, discomfort associated with diarrhea, constipation, then this is the limited diagnostic testing. There's been a lot of guidelines in the world, and I tried to summarize. They don't all agree, but this for the most part. So this is what's recommended. It's recommended that you make a positive diagnostic strategy approach rather than excluding every disease you can think of. And there's a downside of doing that. That's in all IBS patients. It's the diarrhea group where you have to do more workup. So if someone has IBS diarrhea, you do the celiac panel with the anti-TTG, you get the IgA, right? Because some people have a low IgA. So if they have a low IgA, then your anti-TTG, which is IgA, could be normal. So there's IgG as well. Then you get a fecal calprotectin. Now, fecal calprotectin is a good study to get. I know not everybody likes to give a stool sample, but it's helpful to look. You look for IBD. You're looking for an inflammation in the gut. C-reactive protein's not as good as fecal calprotectin, but I get it because I think that some patients are not going to give the stool sample. So celiac serology in the United States, celiac disease in the United States is only about 1%. So we look for it, but it's not that common. But if you have IBS, you're more likely to get it, more based on European studies than the United States studies. If you have a fecal calprotectin that is normal and you have a CRP that is normal, there is a less than 1% chance the patient's going to have inflammatory bowel disease. So when you get that and they're normal and they're not having bloody stools, I'm pretty confident they're not going to have IBD. And then bile acid diarrhea testing is hard to do here in the United States. So often, if you really think the patient has it, had their gallbladder out, or they don't have part of their ileum, or even if they do have that, you could try a, bile acid sequestration if you want. And you just do that as your trial to see if they get better, because you're going to know if they get better within a few weeks, if they're taking an appropriate dose. You get a Giardia stool antigen if Giardia is endemic in your population. In the United States, it's considered endemic, so you get a Giardia. But I will have to tell you, I see a patient with 20-year history, and I'm thinking, should I really be getting a Giardia after this whole time? Like, it doesn't really seem practical. Anorectal physiology testing is getting back to what I was talking about with the rectal exam, looking for pelvic floor dyssynergia. And if you think somebody has it, then you send them for anal rectal physiology testing. Do you have anorectal manometry here? Yeah, you could do you have pelvic MRI? Oh, yeah, I mean, really, you could just get a balloon and see if they could pass it, but I know you have to, use FDA-approved devices. I'll tell you what we used to do in the old days, but here you have to get a FDA-approved balloon. Okay, so on the right side is what is not recommended based on the data. You don't do routine stool testing unless you think the patient had an infection, they have that history. You don't do routine colonoscopy on patients without red flags or alarm symptoms. You just do it as you normally do in any general patient population. Food allergy and food insensitive testing has not been shown to be beneficial currently. And lactulose and glucose hydrogen breath tests also, there's been a lot of debate. I think there will always be debate. I'll probably retire and still be debating this, but in general, it's not recommended by guidelines. If you want, we could talk about it during the Q&A. Okay, so if you've done your limited diagnostic testing, and then you can make that diagnosis. So right now is the Rome 4. So what these Rome criteria are set up, and this is based on factor analysis, so I'm not going to get into that, but you want to have the patients have symptoms for a chronic period of time, so it's at least 3 months. But the criteria is for at least 6 months, but the active symptoms are for 3 months. And because you're trying to make sure it's not something they change their diet for a short period of time, or they have, Giardia, you're trying to reduce the chance they have something else because they've had it longer. So the key is that they have abdominal pain at least 1 day a week, and it's associated with at least two of the 3 features related to defecation. So that means that the pain and discomfort get better or worse after a bowel movement. Can't get worse. It's a subgroup, but it can get worse. And then the pain is associated with a change in stool frequency. Stool frequency, normal stool frequency, which a lot of patients don't realize, is a range. So it's 3 times a day to 3 times a week. That's the normal general population stool frequency. So it's when it's outside of that, and associated with a change in stool form, either hard lumpy stools or loose watery stools. So this is a Bristol stool form scale. I'm sure you've seen that. There's, mugs, T-shirts, a lot of this. It's in bathrooms. Okay, this is what's great about the Bristol Stool Form Scale. So this was developed many, many years ago, where they surveyed the general population to describe their stool, and they realized the general population will describe it in one of these 7 types. And they actually correlated with gut transit time, colon transit time. So the type 1 or 2 stools are the drier stools because it's slower transit, so the colon is reabsorbing fluid. And the faster transit is type 6 or 7 diarrheal stools because it's going through faster, it's not reabsorbing fluid. Now, a drug company came years later and said, oh, we should add pictures to it. But you shouldn't look at the pictures because 1 and 5 look the same. So it's really having the patient read it. Now, this has to be without them on medication, which sometimes is hard. But you have to ask them, what's the percentage of their bowel movements off medication that are these different types, like over the last few months? So if they have at least 25% type 1 or 2 stools, but less than 25% type 6, 7, that's IBS with constipation. If they have more of the type 6 or 7 and less of type 1 or 2, that's IBS diarrhea. And patients who say, I have both, then it's IBS mixed. So that's how you make the bowel habit subtype. And it's important to do that because it's going to affect your treatment. And they can change over time. I brought this out to just show you that we put all of the pediatric and adult, all of disorders of gut-brain interaction, which there's a lot of them, on MD Calc. We spend a lot of time doing this. So if you go on MD Calc, which I'm sure you all use, and type up Rome 4, you will see every pediatric and adult. And we made it into a calculator. So if you just click these, it'll come up, yes, you have IBS or you don't, and then it'll even go through the Bristol stool form and tell you what subtype. And then we also, I don't know if I put it in here, we also put pearls and pitfalls. So we try to put some information that's useful for clinical practice. So sometimes I even forget, like what's the abdominal migraine? Because we don't have that much in adults and children. I'll go in MD Calc and look it up because sometimes I can't remember it. And it's on their handheld too for the phone. So if you ever forget the diagnosis, just go on MD Calc. Okay, so I'm going to summarize just the diagnosis part. Use a positive diagnostic strategy, limited diagnostic testing. You don't need to do an exhaustive workup. It spends a lot of healthcare dollars and it sends the message that you're missing something. The 4 no alarm features. For IBS diarrhea, you get a CBC, fecal calprotectin, Salix serologies, Giardia, CRP, age-appropriate colonoscopy with diarrhea. Oh, you're not doing this, the colonoscopy, but GIs, I always feel bad when a patient with diarrhea is scoped, get a colonoscopy, and they never did random biopsies. Because in microscopic collagenous colitis, it could look completely normal. And the only way you're going to know they have microscopic collagenous colitis is by taking biopsies. It has to meet a certain criteria, and the treatment's completely different. And so I always say, I always write, make sure, or tell the patient if they're going outside, make sure you get biopsies if you're going to get a colonoscopy. Because the prevalence of microscopic colitis in IBS diarrhea is 1.5%, which is higher than celiac. And in middle-aged women, it's 3.5%. So even though 97% don't have it, but you don't want to miss it because the treatment's different. Okay, and then you could do bile acid testing if it's available. We don't have the gold standard in the United States. They have that in Europe, but we don't have that. So use the Rome 4 criteria. We're going to loosen it up in the Rome 5, which is coming out in 2026. You can make a clinical diagnosis. You don't have to use the Rome criteria. If the patient's had symptoms for 2 months and they're bothersome enough to go see the healthcare provider, and they have the symptoms of pain and diarrhea, pain and constipation, you could make that clinical diagnosis as long as you're confident that you did some limited testing to make sure you weren't missing a typical disorder like celiac. Okay, so this is just like a little points that I want to make. Limited diagnostic testing, not a diagnostic exclusion, to get so many different studies. They did a primary care study in Europe, and they showed limited diagnostic testing was better. It saved more money, and the patient's quality of life were better. I think, and I was making this point yesterday, last night at dinner, that I often will explain to the patient when everything's negative. Like I basically don't know how to take care of a patient who has positive tests. I'm so used to seeing everything negative. I almost don't know what to do when it's positive. So that, what you're trying to explain to them, why would they have symptoms if they don't see anything on x-ray or endoscopy? But there's always physiologic explanations, and there's just some simple ones. You can explain to the patient, like typically, why do they have postprandial symptoms? Well, we have a gastrocolonic reflex. So if we eat food, distend the fundus stomach, there's a reflex from the stomach to the distal colon, where it stimulates the colon. That's called gastrocolonic reflex. We all have that. And the larger the meal, the more you're going to stimulate it. So that's why we have postprandial symptoms. That's why we go to the bathroom after eating. And the patients with IBS diarrhea, theirs is much more exaggerated. So that's why we give antispasmodics 30 to 60 minutes before the meal, not after a meal. It's too late. Or we give a tricyclic agent that has anticholinergic effects. They're trying to block or reduce the gastrocolonic reflex that's hyper-responsive in these IBS diarrhea, potentially IBS mixed patients. So that's like an explanation if you explain the patient. I'll even draw, and I'm not a good artist, so they'll understand what I'm talking about, so that they know why they're doing what they're doing. Okay, and then the other aspect that I actually learned when I did the fibromyalgia work is that if you keep repeating the test, the patient actually gets more frustrated. even though it's good news to you and maybe to them, but there's still what's the explanation of my symptoms? So if you keep repeating the test, because I know you feel like you're doing something, but the patient keeps thinking you must be reordering tests because you must be thinking we're missing the diagnosis. So you just want to make sure that you're not perseverating that, because then it's not as helpful to the patient. Okay, so we changed the name to Disorders of Gut-Brain Interaction, which isn't the greatest name, but these are basic collection of brain-gut disorders. And I mean, there's a lot of research with brain imaging, a lot of data on mast cells and microbiome, intestinal permeability. So we know it's the way the brain and the gut communicate. And I come from a group where we do brain imaging, so I understand a lot of the central nervous system processes of how the sensory information from the gut is processed and modulated. So these are a group of disorders that's called DGBI, classified by group of symptoms, and it's related to any combination of the following: motility disturbance, visceral hypersensitivity, altered mucosal and immune function, altered gut microbiome, and altered central nervous system processing of visceral information. If you see any pathophysiology study in IBS, you will never see one of these in every IBS patient. It is still considered heterogeneous, and I think if we can find the subtypes that will guide treatment, that would be, helpful. But when I see a patient, I'm often thinking physiologically, what do I think is happening? And I try to target what we're going to use towards the mechanism I think is driving that patient's particular symptoms. But there's obviously a multifactorial pathophysiology. I show this slide a lot because this is what's going on in my head when I'm seeing a patient. When I see a patient, I'm always thinking, what increased their risk for getting IBS? Did they have family history? Did they have a gastroenteritis and have post-infection IBS? Was there stress in their family life or in their lives that led them to have a dysregulation of these adaptive systems? There's evidence of early life adversity like abuse. That's higher. That prevalence is higher in patients with IBS versus those who don't have it. But I'm always thinking about what's precipitated this has happened. And then I'm thinking the blue box, what are the mechanisms by which of the brain gut axis are driving that patient's symptoms? And then once they have the condition, what you're looking for, what triggers it? And that's really important for the patient to figure out, because that helps them. It's a very unpredictable disorder. I think that's a very frustrating part for the patients, that it's really unpredictable. But the classic triggers are food and stress. That leads to symptoms and consultation. We did a really exhaustive systematic review, and in peds and adults. And what you see here on up here is this was all of the factors that were associated with having IBS in adults and children. So you can see female sex, having gastroenteritis, having histories of stressful life events, and also having comorbid symptoms. The one aspect that's been studied, and there's not that many longitudinal studies, but something to remember, what keeps the maintenance of symptoms is having stress and a presence of a psychological disorder. And that's why you have to address that. I know a lot of GIs don't want to get into that, but we are getting much more behavioral therapy, GI psychologists, because we're realizing how important it impacts the patient and their experience. This isn't adults because there's not that many pediatric studies. There's additional, like you see smoking here, that increases the risk of having these different abdominal pain disorders. So I don't know if you're familiar with post-infection IBS, but that means that someone didn't have IBS symptoms before, they get food poisoning, and then the food poisoning clears, and then they get IBS. So it's called post-infection IBS. It's probably about 10% of the IBS patients. So it changes. There's a lot of studies on this, and they all show it's really the same thing. But you can get changes in the lining of your gut, immune activation. And even though you've healed, the patient's healed, the infection's cleared, you can still have some of these residual changes in gut function that lead to this peripheral sensitization. But what's interesting is that like everybody here probably had food poisoning, but you all don't have IBS, or you don't have functional dyspepsia from the infection. So the patients are repeatedly treated with antibiotics and they don't really need it. The infection's cleared, they just have IBS symptoms. So it's more likely in younger patients, it's more likely in women or girls. It's more likely if you have a severe diarrheal illness, and it is more likely if you have stress or a psychological condition at the time of the infection. So those are the people that are more at risk. So you're getting this peripheral insult, but you need also the central processes to help regulate the normalization of what's going on in the gut. And if you don't have that, then you're more likely to get IBS. So I just want to quickly talk. I could talk about stressful life events all the time because it's really something I hear in my patients a lot. So stress, as I said, is a trigger, but it's also a cause. If you look at childhood adversity, and we say under the age of 18, many people have always described abuse, sexual abuse, physical abuse, verbal abuse. Emotional abuse is one of the strongest drivers of IBS. But also if there's a mental illness in the household, incarcerated family member or mother treated violently. So if you can't ask someone, do you know someone that died in your childhood? It has to be someone like close to them in their household. So that's why the questions are now in your household when you were growing up. People don't really look at what helps patients. We did a study where there was a questionnaire that asked, did you confide in someone at that time? So that's recall though, because it's in their childhood. And if they did, they actually decreased their risk for IBS. So that's something for all of us to remember, that if you have some support and you are able to share with someone you trust or got some counseling, that it can actually help them. And then also stressful lives in adulthood. We did a study, and it's hard to study that because we put every possible life event, and some of them are considered positive, some are considered negative, like marriage. So, if someone might say yes, and then there could be multiple marriages. So it was like a difficult questionnaire, but we got it done. And basically IBS patients will rate potentially stressful life events as more negatively than those who don't, and it affects their quality of life and their symptom severity. And all of these adverse events are related to increased stress response, looking at the HP axis or the way the brain responds in brain imaging studies. So it has biologic, physiologic impact. And stress can affect different aspects of the way the brain processes information and what happens to the gut. See, people tend to think, and I know GIs can often do this, like stress is all in your head, but stress has effects in the body. And I'm sure you know that even better than we do. But you can have changes in the bodily function from stress through neurotransmitters, through the autonomic nervous system, and different mediators. Okay, so the way to treatment is I think the easiest thing to do is think about the patient. If they have mild symptoms, moderate symptoms, severe symptoms. Mild symptoms mean they have symptoms, but they're not impacting their quality of life. They can go to school, they don't miss work. Moderate symptoms means that they're starting to impact their quality of life. They may not go out to meals, they have to cancel on certain occasions. And severe means it's significantly impacting their quality of life. So for mild, you would do more non-pharmacologic treatments, diet, lifestyle advice, make that diagnosis, positive diagnosis, explain, reassure. Sometimes that's all they're looking for. They're wanting to make sure they don't have colon cancer, because someone in their family had it. So you really want to key in as what's important to the patient, why they're here, and just focus on that. I used to do a bigger spiel on everybody, and I just started thinking years ago, you got to focus on the patient. What is the patient asking? So I'll often say, what brought you in? What do you want to make sure we discuss while you're here? Like what's most important to them? And then that's what I'm always focusing on. And that's you just using your time efficiently. Now, if they have moderate symptoms is where you got to bring in pharmacotherapy. If they have stress-sensitive symptoms, you might find ways to help them manage stress. And this is where continuity clinic appointments are really important. It's reinforcement, and then with time, they're starting to learn to take care of their symptoms. That's the goal. It's kind of, like you go to a therapist, become your own therapist. So you're really trying to get them to understand their body. And that's why sometimes doing a diary is not a bad idea in those patients that can't give a good history, because you want them to understand the associations. You don't want to do it forever because then they get too, focused on their symptoms. But you want to give them enough information that they learn how to manage their symptoms. And then severe, you do everything you do with mild and moderate, but this is where you're starting to add behavioral therapies, neuromodulators, and I'll go over that because I know you're probably more comfortable using neuromodulators than even GIs. I just want to talk about communication because I know this is something I'm sure you're all good at, but it's so important in these symptom-based disorders. It's easier if you have a GI bleed or ulcer and you're treating it. But these conditions, this is where communication is even more important. It's always important, but it's even more important. But it really gives you more of that therapeutic relationship. The patients are more satisfied, and unnecessary healthcare visits. I saw a study years ago where they were trying to determine, and they videoed these interactions of the doctor and patient, and I know a lot of people are worried about getting sued. I know we are in California. And they found out that the doctors that get sued are doctors where the patient didn't feel like they listened to them. And then if they have trouble helping them, but if they feel that you listen to what they say, it's less likely that they're going to be upset and try and sue. So I thought that was an interesting part. Okay, so I put this in. So on the left side is what is considered provider-centered care. We did a lot of literature. We published this paper on communication skills for gastroenterologists. And this is patient-centered care. And this is really what you're aiming for. So if you look for provider-centered care, it's where the provider's dominating, controlling the interview. They're doing more of the talking, the patient's doing less. And the provider's not really listening or open to listening to psychosocial issues, which may be important. And the provider's not impact of the illness on the patient's life. The provider selects the treatment, and the doctor decides all the final decisions. The patient center is all focused on the patient and listening to them and actively listening to them. And then, so active listening, I don't know if I have another slide on this. Active listening means that you're listening to what the patient's saying and your response is based on what they're saying. And so you've probably seen conversations of two people talking, and they look like they're talking, having conversation, but if you listen to them, one's saying something and the other one's just waiting to say something, but it's not in response to what that person's saying. So not really having an active listening conversation. So active listening is where you listen to them. So often what I will do is I will repeat, which is called echoing, something they say to make sure they know that I'm listening. So you said that your symptoms were worse when you went on this trip. Can you elaborate? Okay, so I'm now repeating when they said, oh, my symptoms were worse when I traveled. So I say something back every so often so that they know that I was listening to what they said. And then, I type when I am with them because you just don't have enough time. But if they're ever going to bring in something more sensitive, I always stop, making sure I have eye contact with them and listening to them. So I just, and remember that, and probably know this, that nonverbal communication is the strongest form of communication. It's not verbal. And a lot of these patients, particularly in GI, where they've seen many doctors, especially patients I've seen, is they've already had maybe some negative experiences. So they're already coming in with preconceived notions, and they're looking at you to see if you're going to give that same response. And some patients will even antagonize, and to me, it's a trap, and not to fall in that trap, but it does reinforce if the physician or healthcare provider responds back in the same manner, the patient will say, oh yeah, see, they're all the same, or there's no one here that can help me. And it may be because they've been through some very negative experiences where someone has told them it's all in your head, or you don't really have something, and who knows what's going on in their home. So you always have to give them the benefit of the doubt, but recognize that they may have had previous experiences that influenced their interaction and their understanding and their acceptance of that communication. I always give options to patients, and then we decide best of what's best for them. So I really try not to tell them what to do. Okay, I don't have time to go into this, but this was a mnemonic for communication skills based on I'm late. Impression, minute, silence, listen, acknowledge, touch, empathize. The point here, because we don't have time, is to just let them speak for a few minutes. Don't interrupt them. They're always going to tell you what's important at the beginning. And I always start open-ended. I don't do a checklist. Like I tell the GI fellows, this is not a GI bleed. It's not inpatient, it's outpatient. I put that aside. You're going to miss aspects of the story if you do a checklist history. How much nausea and vomiting, abdominal pain, you're going to miss the story. So I really allow the patient to take me where I want to get a GI history because I'm a gastroenterologist. I need to know what they have. But the diagnosis is not the hard part. It's all the other aspects that are important. So you just want to listen, take that information, and then, sometimes it's hard because you feel like this doesn't sound natural to you, but, just understanding, empathizing, like here, you listen to what they're saying, you try to understand their perspective, and you may say something like, being sick while going through a divorce must have been very difficult. You've been doing the best you can to cope. I'd like to help work together with you on improving your symptoms. It's always a partnership, and I often use the term we. So we can try this, or we can do this. And so we makes them feel that we're doing it together. Okay, so this is an algorithm that we came up with, which was pretty simple when we wrote our guidelines. So I'm going to go down each side. So of course, the patient-provider relationship is important, education, reassurance, and lifestyle modifications. Sleep is important, diet. But then you go down to routes that are somewhat similar, the IBS-C and IBS-D. So we did first line, second line, and third line. So I'm just going to go through the diet. So fiber is good. Fiber is good for IBS, but we usually give for IBS constipation or IBS mixed. Soluble fiber has the strongest evidence. If somebody does not eat a high fiber diet, and I'm sure you know this, you start with lower amounts and then you move it up because they get gas and bloating, they want to stop. You can also get in fiber-rich foods. The problem with a lot of the foods is they're very gassy. They cause bloating. So you have to think about, things like berries that have fiber, but they don't have this amount of the high FODMAP. This low FODMAP diet, which I'm sure you have used, the key is not to keep the patient on it for a long time. It's only 2 to 8 weeks max. It's really helpful to work with a GI dietitian. There's a lot of dietitians that know how to do this. There's even a low FODMAP for dummies book that I saw that my patient had that she thought was very helpful. There's a lot of stuff online too. But it's not easy and it's expensive. It's a little more expensive. And then if the patient got better, then you do the reintroduction of FODMAP to figure out which FODMAPs they don't tolerate. It's usually the fructan group, onions, garlics, Brussels sprouts, rather than sometimes the fructose or the mannitol group. It's not all the groups. And then if they don't feel any different, then you just go back to the usual diet. And there's a traditional diet. It's the NICE guidelines. You could just follow that. And just avoid the consistent food triggers. The problem that we have is that patients don't know because it's unpredictable. So one day they'll have pizza, they'll have a problem. The next time they'll eat pizza, they don't have they don't have a problem. They say, but I probably shouldn't eat pizza. But so what they do is they whittle down their diet, even though they're not really sure if it causes problems. And then when a patient's on a restricted diet for a long time, it's hard to reintroduce foods, even foods they tolerated. So you really just want to be, that's why I think the dietitians are very helpful, or for the patient not to respond too dramatically and really determine, is this a consistent food trigger? These are different IBS-D drugs. We have rifaximin, bile acid binding agents that work really in the lumen, loperamide, mu opioid agonists, antispasmodics. Alexadeline is a mixed opioid antagonist agonist. And then we have neuromodulators that really work in the afferent nerve and also centrally. So just for first line loperamide, so you can use 4 times a day. That's the max dose. Often patients will say, I feel like it's a Band-Aid. It's not really helping me. I do think it's helpful. I always try to figure out with the patient, do you know when it's going to be a bad day? Because it's usually 2 bad days in a week. This is just very typical. It's not every day. And so if they do know, or if they're going out of the house, then they would take 1. But they get really constipated, but it comes in liquid form. So if they really need to take it, you would take 1. And then if they have 2 loose stools, you take a second one. Typically, when someone has diarrhea, it's going to be in the morning, early in the day. It's not as typical later. So they just have to be concerned about the morning. What am I going to do in the morning or early afternoon? If you want to use a bile acid sequestrant because you're thinking they may have bile acid diarrhea, you can try that. You can use pills or powder, depending what their insurance covers. Most patients like pills, and I always start at like lower dose and then I move it up. But usually within a few weeks, you're going to know if it helps or not. And if it doesn't help, I just get them off of it. And then of course we have antispasmodics. Peppermint oil is a very popular antispasmodic. There's one that's, encapsulated that a lot of people use. It got so popular, they sold it to Nestle. But you also have prescription antispasmodics. I really think a lot of patients want something natural, so they try the peppermint oil capsules. But the key, as I said before, is you always give it 30 to 60 minutes before meals and as needed. If they don't need it that much, you don't want to use it because they get a dry mouth. They can get blurred vision. And most of them just will take it as needed. They just have to know how to take it. That's the important part. Okay, so now I'm going to go through, this is the loperamide, but I'm going to skip this. So do you use rifaximin for IBS? I know. Yeah. So some of the patients will get it from Canada, which, do you ever get meds from Canada? You give them prescription? Yeah. Yeah, this is expensive drug, but I'm in Los Angeles, so it's used all the time. Okay, so rifaximin is a broad spectrum antibiotic. It's used for traveler's diarrhea and for hepatic encephalopathy. For IBS, it's 550 milligrams 3 times a day for 2 weeks. They did a repeat trial because the FDA knew it's only 2 weeks, and are you going to keep giving people IBS diarrhea with these drugs like multiple times? They want to see the safety and the efficacy over time, so they got 3 treatments. So I'm in my yellow boxes, I'm giving you practical tips. If you ever decide to use rifaximin, if your patient can get it, it's always important to link the diagnosis with the dose. And it's for IBS diarrhea, not for small intestinal bacterial overgrowth, which a lot of people think it is. And so it's 550 milligrams TID for 2 weeks. It's very safe to use. Some people, there's conflicting data whether if you do a lactulose hydrogen breath test, if that helps predict who's going to respond to rifaximin, but we can talk about that if you want to. Alexa, do you use this medication, which is Viberzi? Okay, so it's kind of like a ultra strength loperamide, but it works on 3 different opioid receptors, not just the mu opioid. So this has been shown to be efficacious for IBS with diarrhea, helping pain and diarrhea. It even helps people who have failed loperamide. So there's 2 different doses. There's 75 and 100 milligrams, and you could use either dose, and you take it with food. The key with this, I don't know if you know this, but on the mu opioid receptor, it can cause spasm of smooth muscle. So it does that in the biliary sphincter. So some people get sphincter vodi dysfunction, and there's also a risk for pancreatitis. So you can't give it in people who don't have their gallbladder and people who've had pancreatitis or they drink more than 3 alcoholic drinks a day. This is where you find out if someone really drinks or not. When you tell them that, like, you can't take it if you drink more than 3 drinks. I'm like, oh, I bet I shouldn't take it. So then you kind of know how much they really drink, but you don't want to do that because they can get pancreatitis. Now, this is something you might be interested in using. This is glutamine. So glutamine is amino acid, and they showed in a study that patients with IBS diarrhea have a certain microRNA that reduces the synthesis of glutamine. And glutamine is very important in our body because it's the energy source for the lining of the gut, the epithelial cells, more for the small intestine. So they took patients with IBS with diarrhea that were post-infection because they were more likely to have increased intestinal permeability. And in those patients, they put them on glutamine, and they randomized them glutamine or the control, which is whey protein. And it's 5 grams TID. It's powder. You can buy it over the counter. You just scoop it 3 times a day. So they did it for 8 weeks, and they measured the permeability using this lactulose mannitol urine test. And then they watched them for 8 weeks on one of the 2 interventions, and then they measured intestinal permeability. And then the individuals with IBS that got glutamine, they had a normalization of their intestinal permeability. They had a change. So they normalized it, and it correlated with the improvement of the IBS symptoms. Where in the whey protein, they didn't see any change. So I think for patients, if they don't want a pharmacotherapy and this is cheap, they can try with IBS diarrhea, whether it's post-infection or not. I don't think that's really important. You don't know if they have increased intestinal permeability. I'm not completely sure that's the only mechanism by which it works, but it's an easy thing for them to try. They can stay on it. It's not going to hurt them. But if they don't get better in 8 weeks, you just get them off. So that's something you could try. Okay, so then we have our neuromodulators. These are the different ones. So tricyclics we use as first-line treatment for pain. SSRIs in GI studies have not been shown to be beneficial for GI symptoms, except for functional esophageal pain. Otherwise, in the abdomen, it's not effective. So we really use it more when we think the psychological factors or the mood are driving their symptoms. SNRIs, I love using duloxetine a lot. It has less side effects than tricyclics, so I use that a lot. It's a good, tricyclics are SNRIs. But they're not pure SNRIs. They have antihistamine, anticholinergic effects. But this is also effective for pain. And tetracyclic antidepressants, I use them too, particularly mirtazapine, which is good for upper and lower GI symptoms. It helps mood and helps sleep. But there's some weight gain associated with it. This is some tricyclic, but you can see how many receptors it acts on. So it's more of a dirty drug. There is a study not that long ago that showed low dose amitriptyline is effective. I start at 10 milligrams, maybe 25, but you usually will have to move up. 10 is too low. So if you look at the different tricyclics, you can see the different receptor activity. So amitriptyline is going to be the most sedating because of histamine. It's going to be the most constipating. So if you don't want as much sedation, you don't want as much constipation, you've got to use disipramine or nortriptyline. So these are my tips for you. If somebody has IBS with diarrhea and they need sleep, because poor sleep is associated with worse bowel symptoms the next day. That's been shown in a couple studies. So if I do that, I always give them amitriptyline. But if they don't have diarrhea that much, or they don't want to be sedated, I give them nortriptyline or disipramine. They're pretty comparable. All the doses are comparable. Start low, 10 milligrams. Then I go to 20 milligrams, 30. I usually stay about 20 to 30 for a little longer, see how they do. I'm aiming for the lowest, best tolerated dose. So you don't raise it more than 10 milligrams per week. If anybody has a side effect, then I keep them on that dose for a couple of weeks before I raise the dose. But you can also start at 25 milligrams, go to 50. We usually for IBS don't go higher than, usually it's between 30 and 50 milligrams, sometimes 75. The one condition that I go up to 75 at least is cyclic vomiting syndrome, which is separate. Okay, now there is some evidence that these neuromodulators have a neuroplasticity effect. So after the patient is doing well for 6 months minimum, but usually 12 months, I start tapering it off, thinking that they've learned to manage their symptoms and that maybe they have some sustained neuroplasticity effect. So I don't keep them on forever, but there's some patients I try to taper and their symptoms come back and then we go back on it. So that might happen too. Okay, so tricyclics, use it for chronic abdominal pain when pain is a predominant symptom. If pain is not a predominant symptom, they have some discomfort, I wouldn't go to this, I would use something else. And then I use duloxetine a lot if they're having side effects or it's too constipating. Duloxetine is a little constipating, but not like a tricyclic, and it's not sedating. But the key with duloxetine, if you're going to use it for IBS and for pain, for GI pain, you have to go to 60 milligrams. If you could stay on 20, 30, it's not going to do anything. You have to raise it. So we usually do 30 milligrams once a day for a week, and then we double it 30 twice a day. And if they tolerate, we go to 60 once a day. Mirtazapine is a great drug for functional dyspepsia, IBS, diarrhea, 4 doses, as you know. So it helps all of these symptoms. It's just that you can get some weight gain. So even people who lose weight don't want to go on it, but it's a really nice one. Not everybody gains weight, but you have to tell them because it's pretty common. What's interesting, and you may know this about mirtazapine, once you go above the 30, it's actually less sedating. So it has a paradoxical effect with sedation. And SSRIs, you can use it for functional heartburn, functional chest pain, but really for abdominal symptoms, you're only doing it if you're treating a mood disorder, and you can combine SSRIs and tricyclics, especially low-dose tricyclics. They're usually not going to get serotonin syndrome. So this is really just summarizing the different treatments. And I use a Dansitron a lot for IBS diarrhea. Because you probably don't use a Lositron, which is a 5-HT3 antagonist like a Dansitron. You can use a Dansitron. They did an IBS diarrhea study. It doesn't help pain as much. So you start at 4 milligrams once or twice a day. You can move up to 8 milligrams 3 times a day. So you can use a Dansitron. And it's pretty cheap if you go in that Cost Plus pharmacy. Okay, so these are the actions of the IBS-C treatments. We don't have testosterone anymore. So PEG, I usually start at one. You probably do that one capful a day. I will double it. Sometimes I use 4. I'll do 2 twice a day. Then they start really getting gas pain. But you can do that. Sometimes I even use it a little bit as a bowel prep. Like if someone calls me and says, I haven't had bowel movement in 7 days, usually it's going to take a lot to get them going. I either use a stimulant laxative or I say take 1 to 2 capsules of PEG every 1 to 2 hours until you start going. Once you start going, you stop because you're not really doing a bowel prep, but it'll get them going. All right, these are the different FDA-approved medications for IBS. They basically bring chloride, sodium, and water in the lumen of the gut. Tenapanor has a little bit different. It blocks the reabsorption of sodium, but they all kind of have the same net effect. The key with them is in the ones that have different doses, like these two, you have to match the right dose with the right indication, or the insurance will not cover it. So the higher dose with linaclotide is IBS-C. The lower dose of lubiprostone is for IBS-C. If you're not sure, just put CIC and IBS-C and check both. If you're not sure, because you don't want it to get rejected. But you can usually get both, and lubiprostone now is generic. Plecanatide works a lot like linaclotide. Some people like it. They think it causes less diarrhea. You can crush this one. You can open the capsule and put it in fluid too to adjust the dose. Okay, so what I find there's a lot of constipation meds, and the patients that I see are on too many of them. And so they constantly feel like they have to go to the bathroom. And I have to try to tell them it's not because you have a lot of stool, it's because you're taking too much, it's stimulating your colon. So I teach them how to use the Bristol stool form scale. If they still have hard stools, they need to increase the treatment. If it's too loose, they're taking too much, and this is really what they're aiming for. If you teach them that, then they can adjust it themselves. The other things I didn't go over is that 2 kiwis a day and 5 prunes a day have been compared to psyllium, and those can also help. 2 kiwis a day had less side effects, but it has laxative, has fiber. So you can think about that in your patients. You know, a lot of times they go travel, right, and they get constipated. So, you know, if there's a buffet and there's, kiwi, you can, get that. I don't think I have time to go through everything else. There are behavioral treatments that are very effective. And really, a lot of times patients don't want to be on drugs, but it takes time. So you have to give them both. But it really works along the brain-gut axis and the stress hyper responsiveness and also the catastrophizing thoughts that patients can have, which is understandable. I want to show you this. I don't know if you have GI psychologists, and some patients really just need a general psychologist if they have anxiety or PTSD before you do GI. But if you go on the Rome Foundation website, there's a gastro psych. You can look, it's free. And there's a registry. So there's all the GI psychs, looked over every psychologist that want to be on this registry, and they vetted them. But you can look up your state to see who does it, who's trained to do GI psych work. And also you could even see what of the different types of behavioral therapies they have expertise in. The other thing that I would say, if your patients have insurance or they have money, I think gipsychology.com is very good. It's across the country because you have to be licensed in that state to give the treatment. I've done that even in California because our GI psychologists are too inundated with patients. And they've been very happy with the psychologist that is licensed in California. So you could just go on that site. The patient could go on that site and just make an appointment themselves. So there's a lot of, there's also apps. A lot of times patients like the apps and sometimes they don't like the apps because it's not personalized. This one you can't get right now. This one, Nerva, is a gut-directed hypnotherapy developed by a GI psychologist in Monash, same group that did the low FODMAP. It'll give you a week free, and then they'll charge like $150. And then there's Zemity, which is not FDA approved. It's cognitive behavioral therapy. And then Mahana is FDA approved. You write a prescription and then they get the Mahana. It's like 10 modules. So if your patient doesn't have access to a psychologist, you can start with it. App, I do that. I'll start with it. Okay, so I'm going to end with just some comments. Focus on the most bothersome symptom and what's the patient's goals and needs. Active listening, just validating their concerns, is therapeutic. Never forget that. Just listening to them, acknowledging, that's therapeutic. It's not always a prescription. It's not always ordering a test. Identify the factors with their help of what is associated with the onset of symptoms and the triggers. I always focus my history on the onset and when they had symptom flare. And I always go back about a year because it takes a while to really get the physiologic change that leads to symptoms. Make that positive diagnosis, explain the physiologic mechanisms that are leading to them having symptoms, and then tell them why you're targeting the treatment based on those symptoms, and try to use clear, more direct language so the patient understands what you're trying to tell them. Treat symptoms using the evidence, but also really use a practical approach. Set realistic expectations. I always tell them it's going to take a while to get it better. You've had the symptoms for a long time. They shouldn't be thinking that in 2 days all their symptoms are going to be gone, or once they finish the treatment, they're never going to get, once their symptoms are good, they're going to stop the treatment and say, why did they come back? So they need to know that. And then you select treatments, like I'll treat someone different if they have fibromyalgia or they have migraine. I'll think about everything else and then try to treat, some treatment that helps hit multiple targets. And then continuity care is really important, and really using that integrative multidisciplinary approach is important. And that's it. Yeah, I know I went all the way to the time, but thank you for your attention.
Great, we are at 9 o'clock, so we will wrap up, but thank you, Dr. Cheng. I think we feel more empowered to diagnose and treat IBS. Thank you.